Good evening. Welcome to the BAUS sponsored webinar tonight. We've got 60 participants already online. Welcome to you all. This webinar is going to be on the advances in urethral stricture management, and it's sponsored by Laborie and Urotronic. You will have briefly seen the agenda and the faculty in the waiting room, but just to go through it this evening with you, I'll be starting the discussions off with some optimizing approaches to endoscopic management of urethral strictures. I will then pass over to Dr. Sean Elliott, Professor and Vice Chair of Urology at the University of Minnesota. He'll be talking about mechanical and medical therapies that can perhaps improve outcomes with urethral strictures. And he will then pass on to Dr. Karl Coutinho, who is a reconstructive urologist currently practicing in New York City, and remarkably, the only reconstructive urologist in a practice of over 170 urologists, so he must be a busy man. And Karl's going to talk about the Optilume drug-coated balloon in more detail. If you want to ask questions, there is the Q&A available at the bottom of your screen. And we'll be collating the questions, which will be used as a forum for discussion at the end of the session. Please don't use the chat, just concentrate on the Q&A. There will also be 3 polling questions, which are through the talk, where you have the opportunity to answer a multiple choice question to get an instant view of the audience feelings about certain aspects. So if we then just quickly remind ourselves of who we are, I'm Professor Nick Watkin. I'm Professor of Urology at St. George's Hospital, London. I specialize in genitourethral surgery and have been involved in clinical trials of urethral stricture management in particular. Professor Sean Elliott, Professor and Vice Chair of Urology at University of Minnesota. He also is a recognized expert on urethral stricture disease and has been the Secretary and Treasurer of the Society of GU Reconstructive Surgeons in America. And he's also been Principal Investigator of the trials of Optilume. And Karl Coutinho, as I mentioned, is a reconstructive urologist who trained in Mount Sinai and hospitals in Chicago and Cleveland, who also is the only reconstructive urologist in his practice. So in terms of conflicts of interest, I don't have any. Sean mentions that he's been the PI of the 3 Optilume trials, Robust 1, 2, and 3, and also a consultant for Boston Scientific. And Karl has been an investigator in the Robust 3 trial. So let's begin with some optimization strategies for the management of urethral strictures. And really, we're talking about penile-bulbar strictures throughout this webinar. So let's begin with a recent case which just happened pre-COVID. This was a 50-year-old man who'd had 1 endoscopic urethrotomy, a DVIU, about 10 years ago. And he'd had a cardiac stent placed the year before and was on clopidogrel. He had a urethrogram, which you can see on the right of the picture. The upper slide showing an ascending study, the lower slide, the descending study. And clearly you've got a tight mid-bulbar stricture. The specialist he saw suggested a buccal graft urethroplasty. And the patient wasn't sure what to do, so he requested a second opinion and came to see me in my clinic. So what are his options? Well, obviously he could have a urethroplasty, and one could debate whether it was an anastomotic urethroplasty or a graft type urethroplasty. He could have a second DVIU, which had lasted about 10 years from his perspective. He could have a urethral dilatation, and we'll talk a little bit more about that later. He wanted to know what outcome he could expect from the different types of procedures. He also raised the issue of self-dilatation and whether that would be helpful. He wanted to know if he was going to have a urethral catheter, and if so, for how long. He hadn't really enjoyed the experience from his recollection. And he talked to me about whether things could be done under local or needed some kind of deeper general anesthetic, because he'd had his stent and was slightly nervous about that aspect. So I'm going to just highlight some of the guidelines that might help formulate your opinion, and ones that I personally was involved with are the British Association guidelines, which were published last year. And you'll see a number of statements that we made. The first, that basically a DVIU or a dilatation could be curative if this was a first procedure for short bulbar strictures, and that there was no evidence in the literature that one was better than the other. For obvious reasons, we recommend that you should use some form of guidance, either a guide wire or a ureteric catheter, to define the lumen to minimize your complications. And that's particularly relevant for DVIU. And that you should be careful to use, make sure the urine is sterile and provide appropriate antibiotics. And we said that a catheter should be left in for 3 days, full stop. So the next statements are slightly more contentious. The group said that dilatation or DVIU could be used for recurrent strictures, but was essentially palliative, not curative. We then said that clean self-dilatation may have a role again in palliative management of men with strictures, but was not curative. We made the statement that there was no role for stents in the curing or palliation of men with strictures. And finally, we said that any new device that became available must be tested under NHS clinical governance arrangements. We then concluded by saying that urethroplasty was the only curative option for men with recurrent bulbar strictures. So whether you agree with those statements or not, you could choose a number of other guidelines which have been published. Obviously, the AUA's guidance from 2016, which recommended against repeat DVIU. The SIU produced a consensus statement in 2010, which suggests that maybe you could consider a repeat DVIU if it was a favorable stricture. In other words, one that perhaps was short and that recurrence had not occurred early, and in this case we define the early as 3 months. I'd commend you to read the EAU guidelines from 2021, which is their first attempt at stricture guidelines, and it was a particularly well-researched and well-written document. And they concentrated additionally on the importance of symptom scores and the use of validated questionnaires to guide the patient's choice. But all of the guidance, if you put them together, would say the following. It would say that DVIU and dilation had equivalent outcomes, that DVIU should be offered for untreated short bulbar strictures, but to not perform repetitive DVIU or dilatation if urethroplasty is an option. So what do we advise this patient? Well, he's bothered by his symptoms. That was confirmed to me. He was nervous about COVID and anesthetics in general. And he wanted to know more about the evidence for repeat endoscopic treatment. Well, I obviously told him about DVIU, which he knew about, and this has been popular for 50 years. Nothing new for the audience, I don't think. And the evidence was really driven by the paper from John Blandy in 1983, and some of the great and the good of British urology were co-authors of this paper. And they basically said that after 5 years, 50% of patients who had a DVIU didn't need further treatment. And remarkably, at that time, 80% of patients, or more than 80%, actually relapsed with urethroplasty. So if you were faced with the evidence 40 years ago, you would clearly be choosing DVIU. And it basically defined the next 20 years of endoscopic care. A few years later, Chris Hines in South Africa did the only randomized trial to date comparing endoscopic treatments, and that was DVIU versus dilation. And basically, there was no difference in outcome between the two, and that's driven, again, the evidence that the guidelines are stating. He showed that after one procedure, you'd get a 50% to 60% stricture-free rate at 4 years. After one recurrence, it was 20%, but after a second recurrence, it fell to 0%. And we have the most recent data now. This was published just 3 or 4, well, just before Christmas, actually, in European Urology. And this was the results of a randomized trial that was originally conducted by a multi-center team based in the UK. And 200 patients were randomized to either a urethroplasty, which was a bulbar urethroplasty, or an endoscopic urethrotomy, if a patient had had at least one stricture recurrence. And this is the basic summary data. What we found at 2 years was that 38% of patients randomized to urethrotomy had recurred, and recurrence was really defined by return to baseline of symptoms, flow rate, and so forth. And 20% of the patients randomized to urethroplasty also had, by definition, a recurrence. In terms of re-intervention, the numbers were slightly less because people had perhaps delayed their choice to be reoperated on. But similar figures, really. 28% of patients randomized to urethrotomy had had a re-intervention, and only 16% of patients that were randomized to urethroplasty had had a re-intervention. And you can see on the Kaplan-Meier curves this data projected graphically. So perhaps one could say that the difference between urethroplasty and urethrotomy was not really as great as one might have expected from the historical literature. But this was only data at 2 years, and obviously we don't know what would happen in subsequent years. So at this point, I'm going to pause, and there should be a polling question coming up onto your screen. So this is poll question 1 to the audience. In your experience, what is the typical number of dilations or ureterotomies a patient receives before being referred on for a urethroplasty? And you have 4 choices of 1, 2, 3, or more than 3, 4 or more, I should say. Okay, and here we have the results. So the mean number looks like it's, or the median is 40% would have 2 ureterotomies, and 29% at 3, and 17% would have 4 or more ureterotomies. Okay, hold that thought, and I'm going to now pass you over to Professor Sean Elliott, who's going to talk about some additional adjunctive measures for urethral stricture management.
Thank you, Nick. So I'm going to focus on talking about advances in endoscopic technology, I should say, for the management of urethral strictures. You know, the most basic one would be, in terms of the technology we have and the data that's out there, would be self-dilation. Self-dilation does seem to improve the success rates over just standard internal urethrotomy or surgical dilation by the urologist, as long as the patient keeps doing the self-dilation. The stricture stays open at a higher rate than people that don't do self-dilation. But once they stop doing self-dilation, the recurrence rate is just as high as people who never did self-dilation. And this is demonstrated in these 2 randomized trials by Kiergaard and Bodker listed here, where in one of these trials, people did self-dilation for a year and had an 80% success rate after DVIU plus dilation versus 25% if they only did the DVIU, showing that persistent dilation has a better success rate, self-dilation. And then in the other trial, they only did the self-dilation for 3 months and then assessed the outcomes at 1 year, and that showed no benefit. So it does seem to show that stopping the dilation makes the stricture eventually come back. So I would do away with this notion that you hear some people say where self-dilation kind of stabilizes the stricture, and that you can do it for a little while and then just stop. If you think the data there in those 2 randomized trials is a little bit old to believe, there's also this more recent case control study in the Scandinavian Journal of Nephrology demonstrating higher success rates with self-dilation than with DVIU alone. There have been changes in the dilators that have been used over the years. No one's really studied whether one type of dilator is better than another. I've even known some doctors to prescribe a balloon that the patient can use to inflate themselves every other day to keep the stricture open. So people really are trying many different therapies, but we don't know if one works any better than the other. And if you go to the next slide, I believe it might talk a little bit about one of these. It'll be a future slide. I'll talk about dilators that are coated with steroids. But before I get to that, let me just finish up on this self-dilation and why it's not a fantastic long-term option is that it's associated with a poor quality of life, especially in young men or people with proximal strictures. So this data is from Alan Morey in Texas. There's a little bit of a selection bias because he only surveyed men who were referred to him for urethroplasty. So they'd obviously already made up their minds that self-dilation wasn't the way for them. But when he asked them about their quality of life on self-dilation, the predictors of poor quality of life, again, were the younger men. They didn't tolerate it as well, or the people with very proximal strictures because it's more invasive to self-dilate a proximal stricture. So in my practice, I'll use self-dilation for fossa meatus strictures because it's a little less invasive. They don't have to go so deep. Or in some men who are either bad surgical candidates because of medical comorbidities, or just aren't interested in urethroplasty, or may have very difficult to successfully correct strictures, like maybe some after prostate cancer therapy. This data was touched on a little bit by Professor Watkin a few minutes ago. This shows you what the success rates are for endoscopic treatments. He mentioned that dilation and internal urethrotomy have the same success rate, and that the success rate goes down with successive therapies, so that at about 1 year, internal urethrotomy has about a 60 to 70% success rate if it's the first internal urethrotomy or the second one. But once it gets to the third time, the success rate's very low at 1 year and 0 by the second year. So if we want to improve the success of internal urethrotomy or dilation, I mentioned earlier, one way to do that is with permanent self-dilation, but are there things we can do during the DVIU to increase the success rate? And that would be things like, can we inject a steroid or inject mitomycin C? There's over 20 studies out there, about half of which are randomized trials, demonstrating the effectiveness of these different medical adjuvant therapies. The most common ones that have been studied have been steroids and mitomycin. It's been shown that if you do intermittent self-catheterization with a steroid-coated catheter, or if you do internal urethrotomy plus steroid injection at the same time, that it delays the recurrence, meaning that I think it's after 6 months, their success rates are better, but then eventually after 1 or 2 years, their success rates are no different from people who never had the steroid used. Mitomycin does seem to be effective. If you pool the multiple studies out there, the risk ratio of a stricture recurrence is lower than people without mitomycin. And I'll say a few words about whether we can believe those data or not. Other ways to use mitomycin include intraurethral squirting rather than injecting into the tissues. You can use hyaluronic acid squirted into the urethra. And I guess the qualification that I would add to all of these studies is that although they're randomized trials, oftentimes the quality of the studies is pretty poor. The outcomes are pretty variable. Sometimes the success rate is defined by cystoscopy, other times by symptom score, other times by freedom from intervention. The dosing of these drugs is rather inconsistent. How much dose was given each time, how it was given, how many cuts do you make with the urethrotomy, and then after you make the cuts, how deep do you inject the drug? And in which location do you inject the drug? And then lastly, I think this all leads to some high risk of bias. And then in my own hands, I would say I've had complications with mitomycin injection. The complications have mostly been in people with prior radiotherapy, and we've published those data before. People with radiation plus mitomycin injection, we've seen necrosis of the bladder neck and calcification in that area. But I've had good results with it, especially in vesicourethral and anastomotic strictures after radical prostatectomy, as long as there's no radiation. I haven't personally used it, though, in the anterior urethra. So the Optilume here, which is a mechanical and medical therapy all rolled into one device, provides the your typical balloon dilation, which stretches open the urethral stricture, and then also creates micro fissures for the drug uptake. The drug is coated on the outside of the balloon, and the idea is that the paclitaxel reduces collagen formation during this acute phase of wound healing. And perhaps some advantages over the studies that I just showed you using things like mitomycin and steroids could be that we have consistent dosing of the drug. The same amount is on the balloon every time, and then consistent drug delivery because it's delivered circumferentially and is taken circumferentially through these micro fissures, rather than using a needle to inject it in one or two spots in the urethrotomy. And perhaps those injections are occurring a little bit deep and not right where the drug needs to take action. So the Optilume device has been studied in a few different trials now. We have Robust 1, 2, and 3. Robust 1 and 2 were both single-arm studies. Robust 1 was in Latin America, and Robust 2 was the same design, just in the United States as a confirmatory study. And then Robust 3 is ongoing, and that's a randomized placebo-controlled multi-center study. And that one is in the United States and Canada. There's about 22 sites in Robust 3, and Robust 1 or 2 or fewer sites. We enrolled 127 people in Robust 3 and a few dozen in Robust 1 and 2. Follow-up is planned for 5 years for all of these studies. And you can see there that for Robust 1, we've published the 2-year data, which I'll review in a minute. Robust 2, we've submitted for publication the 1-year data. And Robust 3, we're showing you here really for the first time 6-month interim data. In Robust 3, I should say that what happened is we randomized people to either the Optilume drug-coated balloon or standard of care in a 2-to-1 fashion. And you do that because that provides some incentive for the men to want to enroll, because they know they have a 2 out of 3 shot of getting the drug-coated balloon. For those who got standard of care, it was up to the surgeon. They could do rod dilation, DVIU, or plain balloon dilation, and you see the percentages there. A little more detail about these studies. The stricture length generally was 1 to 2 centimeters, with about half of them being slightly more than 2 centimeters. The number of prior dilations was several, especially in Robust 2 and 3. these men had on average 3 or 4 previous dilations. So these are definitely very high risk strictures. And I don't show it here, but several of them had SP tubes in, suprapubic catheters, because they were in complete retention from their stricture. These were primarily, but not only, bulbar strictures. 10% were penile and robust 3. And the etiology was kind of all over the map. I'll point out that 11% of the men in robust 3 had previous radiation. And here's the success rates. I'll show you a couple of graphs, and the color coding in these figures is consistent across the different figures to help with interpretation. So what we've done here is combine the results from robust 1, 2, and 3 all into one graph. And I'll try and explain why I think that's quite helpful. In each graph, orange is the control group from robust 3, of course, because robust 1 and 2 were single arm. And in dark blue there, you see the pooled success rate in the intervention arm, if you were to combine the results of robust 1, 2, and 3. And in kind of a lighter blue is the, and it's going to be the one with the shortest follow-up, just out to say about 12 months, is going to be the intervention arm in robust 3. The first graph here compares the IPSS scores over time, and you see that the IPSS scores rebound to being high in the control arm, and they stay low in the intervention arm, despite which study you're looking at. And I think what's pretty neat is to see that in robust 1, 2, and 3, the results in the intervention arm are almost always the same as each other. It's the same thing if we look at Qmax as an outcome. The Qmax declines over time in the control group, but stays good in the in all 3 studies of the intervention arm. And then here's the real money shot, if you will. I congratulate the makers of the Optilume Urotronic, and I congratulate them because they were willing to do what I think is a high bar for success, which is to have all of these men get a cystoscopy at 6 months to see if the stricture was open. And this gives us, I think, much more objective data and will really strengthen people's ability to believe these results rather than just looking at, say, IPSS scores. Obviously what the patient feels is very important on IPSS scores, but it is great to see that the anatomic success rates map out with their subjective symptoms. So regardless of which of the 3 studies they were in, the intervention arm patients had 75% patents, 75% of them were patent on cystoscopy at 6 months. And the control arm was 27% patent at 6 months, which pretty much maps out real well with Chris Haynes' paper that we reviewed earlier. And then the last outcome would be freedom from repeat intervention. And this obviously introduces some bias because each surgeon may have a different threshold for repeat intervention, but it is what sometimes a healthcare system might care about. And you can see here that in the control group, almost all of them have had repeat intervention by 1 to 1.5 years. And in the active arm, the repeat intervention rates are quite low at about 20%. So we have a little poll here reflecting back to the data we showed you from the Haynes paper. And I don't know if you could bring the slide back to that graph for the audience, but compared to the data from the Chris Haynes paper, in your experience, would you typically find that dilation or endoscopic therapy is actually more successful than seen in the Haynes paper, just as successful as in the Haynes paper, or less successful than is in the Haynes paper? So it looks like people pretty much agree with the results from the from the paper. A few people have had better success, and certainly different people have different success depending on their techniques for endoscopic management. So I believe that concludes my portion of the talk, and I'm going to turn it over to Dr. Karl Coutinho.
Thank you very much, Dr. Elliott. Appreciate the introduction as well. My name is Karl Coutinho. I'm a reconstructive urologist working in the New York City area, just across the border in New Jersey. I'm fortunate enough to be part of a large group of about 170 urologists and the only reconstructive surgeon there. And because of that good fortune, I've been able to treat a lot of urethral stricture disease and treated 29 patients using the Optilume drug-coated balloon in the Robust 3 trial. So what I wanted to speak to you today about is just some of the technical tips and pearls that I picked up doing the procedure that would help you with doing the procedure, and talk a little bit more about the technical aspects. So obviously, we're all familiar with this diagram. The strictures in question as part of the Robust 3 trial were all anterior urethral strictures. So obviously we avoided strictly prostatic urethral strictures and any sort of bladder neck focus with this balloon, and that's what the data is kind of describing. About 60% of all strictures are actually anterior, so that encompassed a lot of patients, and that's why we were able to drive enrollment in our trial to a high number. So this is just kind of a picture of what the balloon looks like. Now, the balloon itself is a pretty standard dilation balloon if you've ever used one before for urethral strictures. The difference is the drug. The drug is not new. Paclitaxel has been around for a long time. It's that combination of the two with the excipient or the medium of transferring the drug from the balloon to the lumen of the urethra, which is new. So the first step in the procedure as part of the clinical trial was mechanical dilation with a non-drug coated balloon, which opens the area of stricture out, creates these micro fissures, these raw edges for the drug to be introduced when the drug-coated balloon was placed. So as part of the trial, we introduced a non-drug coated balloon, a regular urethral dilation balloon, inflated it for about 5 minutes, deflated it, then ensured that the stricture was open to at least 20 French, and then proceeded with our drug-coated balloon. Now, I will say, in the future, and we repeated this as part of the trial because it was part of the protocol, but in the future, some of the things that we were describing is, not necessarily having to use the pre-dilation on certain strictures. The reason we did it here is we wanted to make sure that all patients were treated once, and thus the concentration of the drug that was given to them was the same for every patient. And I can talk more about that later. So the next step, and we saw a picture of this before along with this graph, is inflating the drug-coated balloon. So the drug-coated balloon is inserted over a wire, and under cystoscopic guidance and fluoroscopic guidance as part of this trial, we inflated the drug-coated balloon for 5 minutes and then deflated this. Now, the drug is imparted then on the urethra, and you can actually see it under cystoscopy throughout the urethra in a circumferential manner, in a very even manner. As you can see here, and what we talked about previously, the drug allows an inhibition of cell division and cell growth, which is inhibiting stricture recurrence, and that's really the secret, to this drug's effect on urethral strictures. In animal studies, the drug was seen in the urethra throughout this process of wound healing at 30 days later. And once the pharmacokinetic trials come out, we'll see that it was really undetectable in the bloodstream after about an hour. So it's very localized in the urethral lumen. The device itself is a pretty standard drug-coated balloon. It does not pass through a standard flexible cystoscope. So if you're using a cystoscope that's flexible in the office, for example, you would need to pass a sensor wire or wire next to the scope and then insert the device over this wire. For this reason, after our first couple of these patients, we started using a rigid cystoscope, a standard 21 French rigid cystoscope. We were able to pass the guide wire, 0.038 inch sensor wire through the scope, and then we were able to pass the balloon through that. I inspected the nipples very carefully to make sure that there wasn't anything that was kind of rubbing off in terms of the drug on these nipples or in the scope, and I didn't really see any. But that brings us to kind of our next. And one thing to mention: the lengths of these balloons vary. So there's a 30 millimeter length for shorter strictures and a 50 millimeter length or 5 centimeter balloon for the longer strictures. And we'll talk about how to choose the length in a little bit. 30 French is the most commonly used diameter during the trial. So again, the secret really is the coating, the excipient, which is the medium that allows the drug to be transferred from the balloon itself onto the lumen. It requires the balloon to be introduced into the urethra and then sit there, coated in saline until for about a minute. So this kind of hydrates the tissue and then allows and facilitates the transfer of the drug from the balloon itself onto the urethra, onto the lumen of the urethra. And I think it's that process of keeping it there and allowing the drug to hydrate, the balloon to hydrate, which prevents it from really touching anything else as it's being introduced into the scope. Paclitaxel, as we talked about before, is an anti-proliferative medication. The whole idea is that it's been shown to limit fibroblast migration via its effect on microtubules, thus limiting fibrosis and inflammation and preventing these strictures from coming back. There's also some research showing its effect on signaling pathways, including transforming growth factors, which are influential in this whole formation of an extracellular matrix, which facilitates the stricture formation in the future. The whole idea of durability, in animal models, like I said, it's been shown to last for up to 30 days in the urethra, and in the half-life in the urothelium is thought to be about 3 to 7 days. It is rapidly absorbed into the tissue, and it is resistant to washout because of its lipophilic nature, and you can see that when you're actually doing the procedure. If you have a camera and at the same time, the crystals kind of stick to the lumen of the urethra and they don't wash out so easily. So the advantage of the Optilume balloon is, in my opinion, the best advantage is really its circumferential and very even distribution of the drug. So that, I think, is the main, and that's the reason I'm a main proponent of this device, as opposed to injection therapy, which I've used for example, bladder neck contractures with mitomycin, where there's, some variability in which tissue is getting the medication and which tissue is not, based on the surgeon themselves and also the patient's anatomy. The hydrophobic drug is absorbed rapidly, as I said, and resists, urine washout immediately after, and remains in the system, as I said, in animal models throughout the wound healing process, thus preventing scar tissue formation again. So in summary, this is a standard urethral dilation balloon, which is delivered via a guide wire and placed into the exact location, either under visual or fluoroscopic guidance. We use both as part of the trial protocol for the Robust 3 trial. The excipient, which is the coating which facilitates drug transfer, requires hydration for roughly 1 minute in saline. And then the drug itself, once the balloon is inflated and makes contact with the walls of the urethra at the area of stricture, is anti-proliferative, and not only prevents the scar tissue from coming back, but the actual physical action of the dilation, which we did via a non-drug coated balloon and also this drug coated balloon, stretches that tissue out and facilitates the transfer into microfissures in the tissue. So as I mentioned before, there are 2 lengths for this drug coated balloon. You really want to make sure that you have an overlap of about 0.5 millimeter or so. 5 millimeters, half a centimeter or so, 5 millimeters on each side of the stricture. That gives you two things. Number one, if there's any sort of minute migration of the balloon during inflation, that gives you some coverage. It gives you a little bit of protection if there's any migration. And also, you know, the whole idea of spongiofibrosis and the thought that repeat DVIUs lengthens strictures because of its effect on healthy tissue on either side. This is treating the so-called healthier tissue on either side of the stricture, which may be prone to formation of stricture in the future as well. So you want to make sure there's overlap, and you know, thus you don't want to use a 5 centimeter balloon, which would be the longest size for a stricture that is more than about 4 centimeters. So we're going to show a brief video here, and I'm going to stop a couple of times, just highlighting the actual procedure itself. All right, so important things to understand is once the packaging is removed from the outer box, there's also an inner packaging as well, and that's to protect from light exposure, protect the device itself from light exposure, and to keep everything sterile. It comes with, you know, what you need to have is obviously a guide wire, you know, your cystoscopic equipment, either a flexible or rigid scope, your saline irrigation, as well as contrast media if you're doing a retrograde, but also to fill the balloon so you can identify exactly where you're inflating it, in addition to visualizing it via cystoscopy, and a small Foley catheter for the end of the procedure. You can see here the device kind of been prepared. Here's the wire coming out. And the key here, I'll pause right here if you would. The key here, this is the drug-coated balloon at the end here, which is white, and it's protected by this plastic coating, the shield that's on top of it. So one of the keys is making sure, especially if your hands are wet, that when you remove this protective plastic coating, that you don't touch the drug-coated balloon portion with this white matrix, which is really the drug and the excipient, to anything that's wet, or really onto anything other than putting it onto the wire and sliding it through the scope. You can see here again, minimize the handling of the device. Now here, I'll ask you to pause for 1 second. The surgeon is using a rigid scope, and then on this next portion here, the surgeon is using a flexible scope. So my recommendation, having started by using flexible scopes in a surgical center environment, where I had rotating staff that may have not been familiar with, you know, the device itself, I was struggling trying to have two hands on the scope itself to keep it in the correct position, and trying to talk my assistant through sliding a wire next to the scope and then sliding the balloon over that and then inflating the balloon in a proper fashion. It became to be a lot. And so we switched after our first couple of patients to a rigid scope, as you saw in the first section right before this part. And that allows you to have control with one hand on the scope, sliding the wire and the drug-coated balloon yourself through there, and holding it steady as your assistant inflates and deflates the inflation mechanism to 10 atmospheres. So I highly recommend, if you are doing this, to do it with a rigid scope. Of course, that means that your patients will have to have some sedation. In the future, as you know, if you have the capabilities in your office and good help, it's possible to do this, you know, in the office with a flexible scope. But if you're starting off, I highly recommend using a rigid scope with some sedation as well. So the balloon is inflated in a standard fashion using a pressure inflation device to 10 atmospheres. And so as we inflate the balloon in the stricture, you'll see that the atmospheric pressure in the balloon will drop off a little bit as the stricture gets stretched. So we're constantly, you know, increasing that to 10 atmospheres to keep it at that level for about 5 minutes. You can see that here fluoroscopically while the surgeon is observing with a flexible scope. You can see here the drug, after deflation of the device coating a even manner. You can't really see the bottom here, the ventral surface, but in an even manner, the entire urethra, and overlapping the area of scar tissue, as you can see further in. So following treatment, the balloon is used and disposed of. We used a standard biohazard disposal method. And the idea is not to do anything or touch anything or manipulate the urinary tract after this. So don't pass the scope through that area. Kind of remove everything and pass a small Foley catheter. We inserted 14 French Foley catheters that were silicone on most of our patients. As a precaution, until the PK trial gives us more data on whether or not the drug is still in the semen or in the urine, we've recommended to patients going through the trial not to have sex for a 2-week period, no sexual activity for a 2-week period, and then for use a condom for sexual activity for 30 days prior. Now, men that have partners of childbearing age, again, out of an abundance of precaution, we've recommended as part of the trial to use a condom for 90 days. However, like I said, trials are ongoing in pharmacokinetics to see how much of the drug really is present in the ejaculate and after the procedure itself and in the urine. All right, perfect. So as you can see, very, very quickly, almost instantaneously, there's a improvement in urine flow as the catheter is taken out. And that's not new, right? You know, balloon dilation, DVIU, these all have a improvement in flow immediately. What is remarkable about this is the durability of this. So you can see this graph going out for 2 years with a consistent improvement in that flow as opposed to standard endoscopic treatment or placebo. Keep going on here with some slides. So again, we place a well-lubed, we use 14 French Foleys for these patients at the end of the procedure. We try not to pass anything through the area once the drug-coated balloon is inflated, deflated, and removed. I generally recommend NSAIDs together with antibiotics as per your normal protocol. Mine is to give antibiotics in the operating room as well as for a short period of time afterwards. And the subject should abstain from all sexual activity. This includes masturbation for 14 days. And then for 30 days, they must use protection if they're having sex with a female partner. And those that are having sex with a female partner of childbearing age, we're asking for at least 90 days of abstaining or using protection. Again, this is until we have more data on the pharmacokinetics, and those studies are ongoing. So you can see here, this is just a case study as well as 24-month follow-up with a retrograde urethrogram, the durability of the response of a particularly tight and very proximal bulbar stricture with an improvement, a very good improvement in the flow. These patients are very, very happy afterwards. So in summary, you know, urethral stricture disease, we all know, although there are guidelines for many different sources, many different countries, many different urologic bodies, we don't always see as reconstructive urologists these patients in our office when they're supposed to. And that could be because of lack of availability of reconstructive urologists. That could be for other reasons as well. Some patients just have multiple dilations. Some doctors are just comfortable doing that. This is a better way of treating some patients, and this may prevent some of them from progressing to more invasive procedures. So I'm very excited about this. Like I said, I've had one patient in that 29 that we treated recur. I did his urethroplasty yesterday. You know, I think this represents just a change in the paradigm and something that we can offer our patients that will help them. The durability of response also is something that I'm very excited about, and I look forward to the 5-year data. So we have a little poll question here. Just after hearing all this evidence from Dr. Elliott, Dr. Watkin, and are you interested in adopting this or learning more about it for the treatment of urethral stricture disease? You could just answer yes or no, or just for select patients. All right, and I think in our next slide here, I'm going to turn it over back again to Professor Watkin to discuss the case study. And most people seem interested in this, and I'll be available also to answer any particular questions you have, especially on the technicalities of doing the procedure.
Karl, thank you very much, and Sean, for excellent presentations. So we go back to my second opinion case. This was pre-lockdown. This obviously was pre-EAU guidelines, pre-Optilume availability in the UK, and pre-outcome of the open trial, which was a few months later. So bearing that in mind, you may recall that the case, he'd been offered a urethroplasty, was not that keen. So what did I recommend to him? Well, he lived 200 miles away, and actually it was a telephone consult, and I'd had the urethrogram sent over to me. I offered him a flexible cystoscopic guided S-curve dilator over a Terumo guide wire with no catheter. He was straight on the train, arrived, and went home again within 2 hours with local anesthetic. I telephoned him in October, and his symptom score was 0. He had a normal flow from his perspective and hadn't deteriorated in any way. So it tells you that endoscopic treatment is undoubtedly still an option. It's not necessarily a cure, but for certain patients, and for this patient in particular, it was exactly what he wanted. And if we can improve on this experience with drug-coated balloons, then we should really be revisiting the role of endoscopic treatment more aggressively, more vigorously than we have done in the past. Even though he was talking to a urethroplasty surgeon, I was still very happy with the outcome and the choice that he made. So if we go on now to Q&A, and just some take-home messages whilst some questions are coming through. I think we'd all agree that this is for short, non-traumatic penobulbar strictures. That would be most people's view, and probably just for a first-time patient or one that's had a few recurrences. Patients need to be well informed. They need to know the short to medium-term outcomes, and they need to know the comparative data. And to that end, we're in the process of setting up a British NIHR-funded RCT, which is looking at Optilume versus endoscopic treatment with mitomycin as an adjunct versus standard of care. So this trial, which is still going through for funding, is called Rebus, and we might be able to give some more information about Optilume going forward on this basis. So I can see that there are 8 questions in the chat, and whilst they're being collated, perhaps I could ask Sean a question first of all. Sean, how do you know where the proximal end of the stricture is in the balloon? Do you use on-table urethroplasty with every patient, or are you using a historical urethrogram to guide you? What's your practice?
The way I've done it is to use on-table urethroplasty on every patient. I've done all of these in an ambulatory surgery center, not my office, with a bit of sedation. And I start with urethroplasty and save that image and then use it as a reference as I pass the balloon later during the study. And as you probably saw in Karl's slides, there are these radiographic markers at the proximal and distal end of the balloon, and making sure that those span the area of the stricture.
Thanks, Sean. And perhaps a question for you, Karl. Obviously, you were stressing the importance of not getting the powder moist, and I'm struggling to see how you can do that with the flexible cystoscope, passing it alongside. I imagine there's gel, water-based gel in the urethra. So I'm getting that why you would choose a rigid scope. Perhaps what was your thoughts when you were perhaps learning with the flexible cystoscope about this?
So my thought is, in terms of not getting it moist, it really was when you are preparing the device, when you're touching with your, not to touch it with your hands, especially. Once it gets into the urine channel, it has to sit in saline for 60 seconds anyway, to kind of activate the excipient and allow the transfer of the drug. So at that point, once you're introducing it, it's going to be about a minute or so before it's in position anyway. And so that's fine. What is difficult when you're, at least when you're first starting out. Now after doing almost 30 of these patients, I'm very comfortable doing it with a flexible scope and a good assistant. When you're first starting out, sometimes holding the scope, at the meatus, as well as the head in your hand, and then having someone slide it next to the scope sometimes can be a little cumbersome. So that's why we had switched over, is more for control. Also, I could hold on to the balloon as it was being inflated and the scope and watch it at the same time. I use fluoroscopy, as Dr. Elliott said, but I also verified after the pre-dilation with the non-drug coated balloon. I verified that the stricture was dilated to at least 20 French by passing the rigid scope through it, so I was able to see the proximal end at that time. Now, in the future going forward, if I decide not to use a pre-dilation balloon, I would be relying strictly on the retrograde images and the markers on fluoroscopy to place it in the correct position. Obviously, the distal marker is very easy because you're right there with the camera and you can place it there.
Yeah, thanks, Karl. Well, now looking through the Q&A, perhaps the most obvious question from an anonymous attendee was, and it's to both of you, what complications have you encountered in the use of Optilume? Sean, perhaps you first.
I haven't noticed complications that are any different from patients with standard balloon dilation, a little bit of bleeding perhaps for a day or two around the catheter, no excess amounts of pain, no excess in infection, and that would match with the data we see from robust 1 and 2 in terms of complications. They're quite rare and quite minor.
Karl?
Yes, I agree. It's pretty much the same complications or symptoms that you would see after any dilation. Some urgency and frequency symptoms. Sometimes some blood around the catheter dissipated very quickly. We didn't have any serious side effects. We had a couple of patients have reoperations, but they had kidney stones. So unrelated obviously to this. No issues with erectile dysfunction. No issues with urinary incontinence, even on those very proximal strictures where the balloon may have been traversing close to the sphincter. So, that was also something that I was very conscious of in terms of placement, but we never had any issues with incontinence symptoms afterwards that were new.
And I should say, we scoped all these patients at 6 months, and in no patient was there some kind of a necrotic, non-healing fissure in the urethra as you might be worried about by delivering a chemotherapy drug to a wound you just created.
I had that same experience. There was nothing that was unusual.
There are a couple of questions to do with catheters, and I suppose I could perhaps summarize the questions into one. Any different practice with your urethral catheterization? Are you leaving them longer? Are they getting more catheter irritation? Do you have to worry about the lubricant that you put on the catheter to place it? Is there anything specific you think that might be different for catheter care post-operatively? Sean, you first.
I really don't do anything different. I place the catheter over a wire, but I do that for all my DVIUs and dilations, and it's perhaps extra important in this case because you prefer to just put the catheter through once and not have to jam it in a couple of times and mess up the drug. So putting it over a wire is great. And no, my management of the catheter has been the same as normal. Take it out after 2 or 3 days.
And Karl, yourself, your practice?
Yeah. Well, to be honest with you, I'm using a smaller catheter than I would if I did a DVIU or a urethroplasty. So, and that was because of the study protocol. I was using a 14 French Foley. So to be honest, most patients had an easier time. with the catheters afterwards. I didn't do anything differently. I did not place them over a wire. I used a regular catheter, not a council tip catheter. We did not have 14 French council tip catheter, so I placed them really without any resistance after the dilation. And I agree with what Sean said. In the future, maybe I'll utilize order some special council tipped ones to place over the wire. But other than that, there was no difference with the amount of saline. It was 10 cc's in each balloon, and the same amount of lubricant. There was nothing unusual.
And I don't put catheters in a lot of my patients post-operatively unless they're really young and anxious, and they might bleed. Can you do this without a catheter, do you think?
I think you could. We wanted to have it standardized for the purposes of the study.
Sure.
But I would agree with you. I do several patients in my non-Optilume patients without a catheter, and I think you could do the same here. I wonder about, I think it would be something that would be reasonable to study in the future, because we don't know the effect of the urine passing through and whether that might cause some loss of the drug. So I don't know that we can answer for sure yet.
Okay. And look, just flicking through the Q&A again. One question is, any particular kinds of bulbous strictures that you wouldn't use the Optilume for? And perhaps the counter question, which kind of patients would you think would be better off with Optilume rather than urethroplasty? Sean, any biases or sort of slanting of your clinical decision making?
I think I would continue to reserve Optilume for strictures that are second or third time around treatments. I wouldn't use it as a first line yet, mostly because of cost. I would probably not use it in extremely short strictures that have pretty good success rate with standard DVIU, as you saw in your case you presented. But if I've got a very short stricture and it's his third or fourth time being treated, then of course I would use the Optilume.
Okay, I've got one more question. Oh no, some more. The next one I was going to ask you is, any concerns about patients on anticoagulants?
I didn't particularly have any issues with that. The patients that I had were able to stop the anticoagulation. In my experience, with a DVIU, sometimes I ran into a little bit more bleeding in those procedures rather than the gradual stretching using a dilation balloon. So to be honest with you, I think just that 5 minutes of pressure will do numbers for helping with bleeding. I would be more likely to use this in a patient that was forced to have anticoagulation than another method. And
another one just come through. Would you use the Optilume for recurrent strictures after bulbar urethroplasty and or penile urethroplasty?
Yeah, I think that the Optilume has proved itself to be particularly useful in the difficult to treat strictures, those that have failed 2 or 3 other treatments. So as an extension of that, I would guess that it would have a good role in the management of the difficult recurrences after urethroplasty. I also think it'll prove to have a role in the vesicourethral anastomotic strictures after radical prostatectomy, perhaps in bladder neck contractures after transurethral resection.
Yeah, I also agree. I think that my general algorithm is failing endoscopic management, proceeding to urethroplasty, and failing that, doing another endoscopic management before doing a repeat urethroplasty. So I would definitely consider using the Optilume balloon for those patients to try and prevent that second urethroplasty, which would be a lot more difficult.
I think I'd agree with that strategy. I think your patients were probably saying the same thing, actually. Okay, I think that's drawn an end to the Q&A. I'm just looking through the live chat, which is, I think we've covered everything. Yeah. James, anything coming through from the background that you'd like us to cover before we close the session?
No, I think you've covered everything fantastically. So first of all, I'd like to say thank you to Professor Watkin, Professor Elliott and Dr. Coutinho for taking the time, and also for the audience and everyone in the audience for taking the time to join us this evening. We're really grateful that we got to share this educational opportunity with you guys, and I hope that you can form a very concise clinical opinion, and I look forward to meeting everybody in the future when it comes to the urethral stricture practice, and introducing Optilume as part of that as well, and engaging in further conversation. You know, if anyone has any questions, they can come through to myself, or they can go through via the Laboratory website or the Urotronic website, and we are open to conversation at any time. So thank you very much, panel. I really appreciate your time and your efforts, and thank you very much to the audience, and to everyone in the background who's made this possible as well. And we look forward to working with you all in the very, very near future.
Thank you, James. And I would just like to thank my colleagues, Professor Sean Elliott and Dr. Karl Coutinho, for presenting excellent talks, and also to BAUS, who've set up the educational series over this year. And I think they've become really popular, and we've still got 82 people on the line, which is excellent. So thank you very much, everybody, and good night.